is Professor Mark Sherlock, who, for those of you who don't know him, he's a consultant endocrinologist and professor at Beaumont Hospital and RCSI. Mark and I work very closely together because we both have an interest in pituitary tumours. Mark's an amazing researcher, very, very proliferative, lots and lots of publications, and he's recently become the director of the Clinical Research Centre for RCSI Hospital. So Mark, together with his colleagues, Mick O'Reilly and Amar Aga, they basically have a daily neuroendocrine ward round on our wards, on the neurosurgical wards. We really can't do without them. And they provide a fantastic service, not just for pituitary tumours, but for, as you'll see, for head injured patients, for subarachnoid hemorrhage, and the whole spectrum of neurosurgical patients, because pituitary and endocrine and sodium problems are very common in our patients. So Mark's going to talk about sodium abnormalities in head injured patients, and I'll let you take over there, Mark. Thanks.
Thanks very much, Mohsen. I'm just going to try and see if this works, please. Hopefully it does. Yeah, so thanks very much for the kind introduction, and thanks for the invitation to talk at this neurotrauma forum. So I'm going to try and give a talk on neurotrauma without any imaging. I'm an endocrinologist, I know my place. So really what I'm going to do is talk about sodium abnormalities in neurotrauma patients, and this can be very easily broken down into neurotrauma-related hyponatremia or cranial diabetes insipidus. And we looked at this a number of years ago. I looked at this when I was a reg a number of years ago in Beaumont, and looked at all neurosurgical admissions and tried to see how many patients developed hyponatremia. So if you look across all the neurosurgical floor here, about 5% of patients at some stage during their neurosurgical journey will develop hyponatremia. That was particularly higher for patients who had subarachnoid hemorrhage, traumatic brain injury, and post-hypophysectomy. And what was interesting is if you looked at the patients who did have hyponatremia, they tend to stay nearly twice as long in hospital as patients who are unitremic. So it's an important, I think, sign of morbidity in these patients that they do develop hyponatremia, and probably also a sign of increased complexity. When you look at the breakdown of causes of hyponatremia in this study, the vast majority, 62%, were SIDH, and a lot of those were on medications that could have perhaps complicated matters, such as carbamazepine, DDAVP, or SSRIs, but 1 in 3 patients was not SIDH. They were either hypovolemic, there was some cerebral salt wasting, injudicious or inappropriate IV fluids, and a mixed cerebral salt wasting SIDH picture. So I suppose the first message from this, from a trainee perspective, is that when you see hyponatremia, it does not equal SIDH. It can certainly equal SIDH, but there's a percentage of patients who are not SIDH, and you can get caught out with these patients. So I think it's important to remember when you see these patients that there is a broad differential diagnosis of hyponatremia in neurosurgical patients. Certainly SIDH is the commonest, but you can also have, like any other medical patient in the hospital, you can have diuretic therapy, you can have injudicious IV fluids, you can have cortisol deficiency, cerebral salt wasting, and then cardiac, liver, or renal failure. Or in fact, what happens frequently is you have a combination of diagnoses, and I think this is where the art comes into assessing and treating patients with hyponatremia, is trying to figure out which is the most important etiology in these diagnoses. So what do we do as endocrinologists when we are asked to see a patient with hyponatremia? Well, we divide the classification and workup of hyponatremia into 4 very basic questions. We want to know how severe is the hyponatremia? Is it mild, moderate, or severe? From a biochemical perspective, most importantly, and particularly most importantly in our neurosurgical patients, we want to know, have they any symptoms suggestive of hyponatremia? And I'll touch on those symptoms in a moment. A lot of these symptoms have a significant overlap with other symptoms you'd see on a neurosurgical ward due to cerebral edema and other issues. We then look at what the etiology is, and we would divide hyponatremia according to fluid status. So is the patient dry, euvolemic, or overloaded? And then really importantly, and again, more so than in the neurosurgical context and neurotrauma context than anywhere else in the hospital, what's the acuity of onset? So have we got a normal sodium 48 hours ago and now we have acute drop, or has this patient got chronic hyponatremia? Because the way you treat these is different. From a point of view of symptoms, you either have no or mild symptoms, and this is usually in the patient who has chronic hyponatremia. You can have moderate symptoms and severe symptoms. And the moderate symptoms, and again, these are important to look out for, overlap with a lot of symptoms you would see very commonly in neurosurgical patients. So headache, irritability, nausea and vomiting, mental slowing, unstable gait and falls, and confusion and delirium. And obviously severe symptoms such as stupor, coma, convulsions, and respiratory arrest. But I think because there is this overlap, it's sometimes difficult to tease out, well, is someone's neurological deterioration due to their underlying neurotrauma issue, or is it due to the compounding factor of hyponatremia? And we can usually answer certainly the hyponatremia question by normalizing their sodium, and if their symptoms improve, well, there's your answer, and if they don't improve, it's their underlying neurological condition. So the reason the brain is so, I suppose, affected by sodium is that if you look at a brain when the osmolality is normal, this is very healthy looking, and when you have an acute drop in sodium, you get worsening of cerebral edema. The brain gains water, and then there's a very acute mechanism to stop your cerebral edema and intracranial pressure increasing too much. And this is a rapid adaptation where you lose sodium, potassium, and chloride, and with that you lose water. So this is kind of what happens. The first two figures are what happens in the acute phase where you gain water, and then over 48 hours you slowly lose water and sodium. And then beyond 48 hours, there's a further slow adaptation with the loss of organic osmolytes. And these organic osmolytes are important when it comes to risk of central pontine myelinosis and demyelination. So the things that determine the symptoms in patients with hyponatremia is obviously the severity of the hyponatremia, the speed of onset of hyponatremia, and importantly from your patient cohort, structure and neurological disease, age from a point of view of if there's cerebral atrophy or if they've got quite a tight brain already, and then associated metabolic derangements, which you'd frequently see in ICU. These can all make the symptoms of hyponatremia worse. So let's just do a couple of cases then, just to represent some of these issues. So the first case is a 47-year-old man who was transferred to Beaumont. He fell off a ladder, had a GCS, had a subdural hematoma requiring evacuation, and on admission his electrolytes were normal. And he did very well post-operatively. His GCS normalized. But over the next few days following his surgery and his trauma, his sodium started to drop. So if you look at the top line here, his plasma sodium went 135 to 120 by day 4. His urea dropped by 5.9 from 5.9 to 3. And when you look at his urinary output, he had an antidiuresis. So this is very typical of the syndrome of inappropriate antidiuretic hormone. So low sodium, decreasing urea as water is held, a low plasma osmolality, a elevated urine osmolality, an elevated urinary sodium, a normal cortisol, and an antidiuresis. So this is fairly clearly SIADH. And I suppose the question then arises is what to treat with this patient with. So most patients with SIADH are treated with fluid restriction, but in a neurosurgical setting, and particularly if there's confusion and headaches and symptoms, we don't always treat with fluid restriction. And often, particularly in our subarachnoid hemorrhage patients as well, it's not really felt to be the kind of thing that our colleagues in neurosurgery and neurocritical care want us to do to fluid restrict. So we have to think of another way. And the other way here is around hypertonic saline. So hypertonic saline is a really important way of treating hyponatremia, and I'll talk a little bit about that in a second. From a point of view of the diagnostic criteria of SIADH, there's very clear diagnostic criteria. So when we go up to see consults on our neurosurgical wards, our neurosurgical colleagues and their team have very kindly arranged for them to have urine osmolality, urinary sodium. So we want a concentrated urine osmolality. We want an elevated urinary sodium. And we always check thyroid function and cortisol. This will be really important in defining the diagnosis of SIDH. From a point of view of hypertonic saline, we use a lot more of this than we probably did 5-10 years ago. There's been recent guidelines in the literature regarding hyponatremia. And the indications for hypertonic saline is, one, if you have a known duration of hyponatremia. So for example, you have a patient in a neuro ITU or in a neurosurgical ward who came in with a sodium that was absolutely normal, and 48 hours later the sodium has dropped precipitously. The second is if you have intracranial pathology or increased intracranial pressure due to any other cause, because added cerebral edema from hyponatremia will not help this situation. And obviously if you have any significant neurology like seizures or coma, then you would certainly treat with hypertonic saline. And the goals are really urgent correction by 4 to 6 millimoles per liter to prevent any worsening of brain herniation or any other compromise. How do we do this? Well, there are two ways of doing this. You can give boluses of hypertonic saline, so 100 mils of 3% saline infused intravenously over 10 minutes, and this can be repeated up to 3 times as needed. If you're going to do this, these patients ideally should be in a critical care environment with frequent assessment of sodium. That's for boluses. The other way is to give a slow infusion, and this is particularly helpful for mild to moderate symptoms, of 3% saline, and you can infuse that at anywhere between 0.5 to 2 milligrams per kilogram per hour. I have to say we use more boluses increasingly now than infusions, because we find them more controllable and that we get quicker results from a point of view of improvement in sodium and ultimately improvement in GCS. And if you're going to give hypertonic saline, then these patients need to be really closely monitored to ensure they don't overcorrect. This is some data from our group, Aoife Garrahy, who worked with myself and Chris Thompson for a number of years. And this is looking at our data in relation to bolus of 3% saline versus infusion. So just to orientate you, bolus is in red, infusions in blue. And on the left-hand side of your screen, you can see a change in plasma sodium, and that's at 6 hours, 12 hours, and 24 hours. And what we really think now is that the critical time is in the first 6 hours. If you're going to improve someone's sodium and ultimately improve their GCS, what you want to do is get their sodium up in the first 6 hours by approximately 6 millimoles per liter. And that's exactly what the bolus does, whereas the infusion is slower. Now, what you can see is at 6 hours, the rate of rise for the bolus is much higher, but at 24 hours, it's similar. And then the figure on your right is changing in GCS, an improvement in GCS. And again, by giving boluses in red here at 6 hours, there's a much more significant rise in GCS. And we think this is important, particularly in our critical care patients, who 6 hours is an important time window to try and get their sodium up and their GCS up as quick as possible. By 24 hours, the two methods are of similar efficacy. So moving on to case 2 then, there's a 21-year-old man who was transferred from peripheral hospital up to Beaumont with a traumatic brain injury following an RTA with multiple frontal contusions, basic skull fracture, and a decreased GCS. He's admitted to our neurocritical care, and on admission his sodium was normal. And over the next few days, he was felt to not really be improving as would have been expected. He was still inotrope dependent from a blood pressure perspective. He was slow to wean from a ventilator, and he had a fluctuant GCS. And over those 5 days, what had really happened from a sodium perspective is for the first 3 days, pretty normal. And then day 4 and 5, the sodium started to drop. This was associated again with a drop in urea and again with an antidiuresis. So he looked, for all intents and purposes, very similar to our first patient. But actually the difference in this patient was that his cortisol was 110 and his glucose was low at 3.1. A cortisol of 110 in the setting of being on inotropes is profoundly low and is diagnostic really of acute pituitary insufficiency and acute cortisol deficiency due to pituitary trauma. So that's what we diagnose them as, acute cortisol deficiency secondary to hypopituitarism. And the treatment options in this patient is not fluid restriction. It's not necessarily IV 3% saline either, unless there's a significant drop in GCS. the treatment option is really hydrocortisone replacement with intravenous hydrocortisone. And this is usually enough to normalize sodium on its own. The whole concept of pituitary dysfunction in the acute phase post-traumatic brain injury is a relatively new one in the last 20 years. And really some of the standout data from this comes from Amar Aga and Chris Thompson and the unit in Beaumont. And what we found was that about 16% of patients following a traumatic brain injury have an element of cortisol deficiency, and about 26% or 1 in 4 patients would have AVP deficiency or cranial diabetes insipidus. So these patients who have traumatic brain injury are very high risk of neuroendocrine problems. And as Mohsen says, we do a daily ward round on our neurosurgical wards from a neuroendocrinology point of view, and pick up a lot of these patients during these assessments. So I think it's really important in a take-home message is that acute hypopituitarism causing hyponatremia should be considered in all cases of hyponatremia in neurosurgical patients, but particularly if there's a problem with their blood pressure or any sign that their glucose levels are on the lower end of normal or low. This should be a real red flag. I think everyone who has hyponatremia in a neurosurgical environment should have a cortisol check and to be treated for cortisol deficiency if found to be the case. Moving on, in the interest of time, then the next most common problem we face from an endocrine point of view is diabetes insipidus. So the pituitary gland really controls your salt and water balance. There are other things that control it, such as sweat, pulmonary, but mainly it's the pituitary talking to the kidney. And vasopressin is produced in the hypothalamus and released in the posterior pituitary into the bloodstream. It then goes on to the bloodstream to have an effect on the distal convoluted tubule to control water balance and concentration capacity of your kidneys to concentrate urine. And just to, I suppose, have a schema of this is nephrologists love this kind of picture. I'm not so sure how much neurosurgeons do, but this is a glomerulus and a loop of Henle. And what you can see as you go across the loop of Henle, you can see that the urine is concentrated. So by the time at the very end here, you have a urine osmolality of about 1200 milliosmoles per kilogram, really concentrated urine. And that's because if you look up here, vasopressin sticks onto the vasopressin V2 receptor and concentrates urine. What you have in cranial diabetes insipidus is no vasopressin. And therefore what you have, and we see this in clinical practice, is the inability of the kidney to concentrate urine. So we can go around on our ward rounds and look at people's urinary collection bags and see very clear water-like urine and say there's a high chance that that patient has diabetes insipidus. That combined with thirst or increased urinary output or increased sodium is a real red flag. And I suppose it's all about the pre-test probability that if you've had a traumatic brain injury and are pouring out urine and your sodium is going up, the likelihood is that you have diabetes insipidus. So let's go to a next case. It's a 56-year-old woman, 2 days following traumatic brain injury and acute subdural hematoma, and now has polyuria and polydipsia. And this will be a very typical consult from our neurosurgical colleagues. The urine volume in the last 24 hours has been 6 litres. The urinalysis is normal. The sodium is 146, so slightly elevated. Potassium is normal, glucose is normal. The plasma osmolality is elevated, but the urine osmolality is inappropriately low. So if your plasma osmolality is elevated, you'd expect to maximally concentrate your urine. So this is a very abnormal picture and is diagnostic in itself that this patient has diabetes insipidus. And this comes back to the whole concept of how the body controls water homeostasis. So in the setting of dehydration, such as this, you get an increased plasma osmolality, which impact on hypothalamic osmoreceptors or are sensed by hypothalamic osmoreceptors, which do two things. One is to increase thirst, and the second is to release vasopressin. So if your patient is conscious, they will feel profoundly thirsty. Patients we really worry about are those who develop diabetes insipidus who are unconscious and therefore don't have a thirst response and can't take water intake. Because if you can take water intake, then you will often balance out and not become too hypernatremic. If you can't take in a water intake and you have no antidiuresis, you're losing massive amount of water, then your sodium level will rise. You can normalize your body water. In fact, you can become quite dry if you don't recognize this, and you can. This is if you've got none of this antidiuresis. If you have an antidiuresis and you're taking lots of water, everything will normalize of its own accord. So it's really important to think, is my patient able to drink? Are they thirsty? If they're not able to drink, or say their GCS is low, or for other reasons, then there are particular risk in diabetes insipidus of developing significant hypernatremia. So this patient was diagnosed with postoperative diabetes insipidus. The treatment at that point was a single dose of 1 microgram DDAVP subcutaneously, and this had a very good symptomatic effect. It also normalized the sodium and it decreased the urine output. And what we do in these patients is we don't give them regular DDAVP. We monitor them very closely and look for reoccurrence of cranial diabetes insipidus prior to giving them another dose. 1 microgram of DDAVP will last anywhere between 12 and 24 hours. So we would look at for recurrence of cranial diabetes during this time. Sometimes 1 microgram is enough if it's just transient diabetes insipidus, but sometimes you may need more. And on day 6, this patient had only had 1 shot of DDAVP, but then developed hyponatremia. And it was very typically in keeping with SIDH. And we treated with fluid restriction as the patient wasn't very symptomatic at this point. And the sodium absolutely normalized over the next 3 days. And then day 9 post-op, while being fluid restricted for the SIDH, the patient developed a sudden onset of polyuria with 6 liters of urine output in over 24 hours, and the sodium went up again. And this would be really in keeping with something that's relatively rare, but if you miss it, their electrolytes can really jump around quite a lot. And this is the triple phase response. And the triple phase response is where the patient gets an initial diabetes insipidus, which needed to be treated with a stat DDAVP and dextrose, followed by SIDH, treated with fluid restriction, and then followed by the reoccurrence of diabetes insipidus, which is then permanent. So it's a classic triple phase response. And the mechanism of this is that initially you get some stunning of the hypothalamus and posterior pituitary with the absence of release of vasopressin, which gives you transient diabetes insipidus. Then, because the hypothalamus is damaged and the posterior pituitary is damaged, you get unrestricted vasopressin release of preformed vasopressin. And then once all this preformed vasopressin is released and there's no further new synthesis of vasopressin, you get permanent diabetes insipidus. And these patients can be quite challenging to manage and need very close monitoring. So in conclusion then, I think sodium abnormalities are very common in neurotrauma patients. I think it's really important that the differential diagnosis of hyponatremia is broad and not always due to SIDH. Hypertonic saline boluses and infusion can be life-saving in the setting of acute hyponatremia. As said, I think we're starting to use more and more hypertonic saline boluses rather than infusions, and we can talk about that later. Cranial diabetes insipidus can be transient, and it's important to only give PRN DDAVP initially, because if you just give regular DDAVP, the patient can become hyponatremic, and you don't really know if this is just transient. And I hope I've convinced you that neuroendocrinology is an important part of the neurosurgical and critical care team managing neurotrauma patients. So thanks very much.
Thanks very much, Mark. That's a fantastic overview of the kind of sodium problems that we see in the trauma patients and in the neurocritical care setting. It kind of just demonstrates the whole thing. I would like everybody that's listening, that those couple of papers that you mentioned that came out of Beaumont with Amar Aga, yourself, and Chris Thompson in Journal of Clinical Endocrinology and Metabolism 2004 and 2005, they're definitely worth looking at. I think they were some of the first papers worldwide showing the effect of traumatic brain injury on pituitary function. And I suppose today we're kind of covering the acute effects of it on pituitary function. We probably need a separate session on the chronic effects of TBI on pituitary function and hypothalamic function. A few questions. Just you covered some of this, but I just want to go over the hyponatremia correction and the speed at which you correct. Can you just tell us again how quickly to do it, but how not to do it too quickly? Just go over that again for me.
Yeah, so I think it really depends. The first thing to say about that is that if you're in any way worried, you would have a kind of 8 millimole in 24 hours kind of limit. There are some patients who you have a 6 millimole in 24-hour limit, and they're patients, say, who are alcoholics, alcoholics, who are malnourished, and the limits are really set, and they're not a target, they're a limit. So they're really set to avoid osmotic demyelination and central pontine myelolysis. That's particularly of a greater concern in patients with chronic hyponatremia. So hyponatremia, we would consider chronic to be greater than 48 hours. However, in some of your patients in neuro ICU, they will drop their sodium within 12 to 24 hours. There's not as great a worry about them osmotically demyelinating because they haven't had that adjustment within their brain. They haven't lost their organic osmolytes. They still have their buffers. So if you see somebody who's dropped from 136 to 124 in 24 hours, it's okay to get them back up relatively quickly. It's the patients who you don't know how long they've had a low sodium for, or they've had a low sodium for weeks, that you would be really cautious in overcorrecting them. But as you know, Mohsen, we would see a lot of patients who have a neurological deterioration very abruptly if they drop their sodium in 24 hours. And we think it's really important that those patients get their sodium back up as quick as possible, to help with their neurological status. So if it's chronic over 48 hours, somewhere between 6 and 8 is usually safe. If it's acute, less than 24, 48 hours, you can kind of get the sodium back up a bit more robustly. But the key thing is that you stop once the neurological symptoms have improved. It's not about chasing the number, it's looking at the patient, has their neurology improved, and then you can stop. And we would use a fair bit of desmopressin. If you think somebody's overcorrecting, we give desmopressin to stop them going up any further, and it works really well, desmopressin and dextrose. But, and the people working Beaumont will know, you just pick up a phone to a friendly neuroendocrinologist and we'll do all this for you. But I think it's really important. It's a really important question because it's the thing that worries people most is overcorrection.
It is. There's a whole sodium issue is a bane of our lives, to be honest. But there's a question about tolvaptan as a drug, how it works, and can you use it in this sort of scenario?
Yeah, so tolvaptan is a vasopressin receptor antagonist. So essentially what tolvaptan does is it gives you diabetes insipidus. So it's a treatment that's there for SIADH. It's really licensed for chronic SIADH, not acute SIADH. And there's one paper from Germany that looks at this in an acute neurosurgical hyponatremia group, and they tend to correct quite quickly. So we tend not to use it in the acute setting because one, SIADH is usually quite transient in patients who have acute hyponatremia in a neurosurgical setting. The patients who have chronic hyponatremia due to SIADH are lung cancer patients, etc. So we would see most of our patients in a neurosurgical and neurotrauma setting have very transient for 7 days max. So we tend not to use it. If the people need to get their sodium up quickly, we tend to use hypertonic saline, and then we can add in fluid restriction. So I don't really see it having a huge role in your cohort of patients because I don't think they need it long term. Most of the time, sometimes we will use it in rare circumstances. And the other thing is I think it will often jump their sodium quite quickly if you use it, so we tend to avoid it.
It's effectively dehydrating you, isn't it?
Essentially, you give them diabetes insipidus.
Yeah.
You do the absolute opposite of SIADH, and you give them diabetes insipidus, so they become quite polyuric and they can overcorrect their sodium quite quickly in the acute setting like this. So chronically, we use it a lot, but not in the acute setting.
Very good. There is a question coming in here. It says many neurosurgical trauma patients don't have the benefit of transfer to the neurosurgical unit. You're right. It is a big problem. Does this mean that management is suboptimal without the input of a multidisciplinary team? Any suggestions for peripheral units?
Well, I think, you know, most hospitals will have an endocrinologist, you know, in Ireland. It's certainly, there's a slight, I suppose there's different training for neuroendocrinology, and it's something, these patients can be quite tricky to manage, and they need a lot of monitoring. I certainly think if you've patients whose sodium levels are abnormal, following a TBI, those patients, if their GCS is in any way compromised, they should be in a critical care environment, whether that be in neurocenter or outside a neurocenter. From a point of view of MDT input, I think that's probably a discussion beyond my pay grade, but I think it's really important. You know, we see it in the importance of working with our neurointensivists and working with our neurosurgeons very closely about decisions.
Yeah, I think that's a really important point, actually, that's brought up. And, you know, the problem we have always had is lack of resources. And the reality is that I think moderate and severe traumatic brain injury should be managed in a neurosurgical center with a full multidisciplinary team behind us. And maybe, hopefully, someday we'll get to that where you have enough resources so that all moderate and all severe head injuries come to us, and they shouldn't be. You know, we should have the resources to do that. So I'm going to stop there talking about that, or I could go on all night. Mark, that's been fantastic. I'm going to move on to the next presentation. Really, really excellent talk. Thanks very much.
Thanks, Moses. Thank you.
So our next speaker is Suzanne Murphy. Is she there?
I am. Hi,
yeah, there she is. And she's going to talk to us about decompressive craniectomy and cranioplasty in the traumatic brain injured patients. Thanks, Suzanne. It's a very good topic because since the publication of the Rescue ICP, we do more and more. There was a randomized trial looking at decompressive craniectomy in traumatic brain injury patients, and we're doing more and more decompressive craniectomies. And then we have to do the cranioplasty. I think, Suzanne, you're going to talk to us about that. Suzanne's one of our senior house officers in neurosurgery in Beaumont at the moment, and she's doing the presentation with Mr. David O'Brien, one of my colleagues. So go ahead, Suzanne.
So, hi, my name is Suzanne Murphy. I am presenting about decompressive craniectomy and autologous cranioplasty in trauma. So, I think, Becca, thank you so much. So, talk about head trauma. There's 449,000 UK emergency department attendances per year with some degree of head trauma. It's the leading cause. Trauma is the leading cause of death under the age of 45, and up to half of those are due to head injury. So, just to give an idea of the impact that can have on patients. So 50% of inpatient adults can have morbidity from a head injury. If we can move on. So I'm just going to talk you through a case of a patient we had recently. This was a 68-year-old gentleman. He was admitted to his local emergency department by ambulance after an unwitnessed fall. His daughter heard a bang and found him unresponsive. On arrival to the local ED, he was found to be unresponsive with a GCS of 3 out of 15. That's E1, B1, M1. His pupils were both reacting, but sluggishly, and there was a slight difference between them. Of note, he had no known medical history. He wasn't on any blood thinning medication, and he would have been independent at his baseline. So he was transferred over to Beaumont for acute treatment. So this is just his initial scan. So his initial CT brain showed a large intraparenchymal hemorrhage with left subdural hematoma, an extension into the left lateral ventricle with significant midline shift. There was also evidence of basal skull fracture. So he needed an emergency left temporal frontal decompressive craniectomy with evacuation of an acute subdural hematoma. And at that point, the bone flap was transferred to the abdominal wall. So craniectomy is any procedure where a flap of bone is removed to allow access to the skull and to help relieve pressure on the brain. Craniotomies, craniectomies, and cranioplasties are not new procedures, and there's archaeological evidence of them from as far back as 7000 BC. So if we can move on to my next slide. Thank you. So this is just to remind everyone of that med school slide of the Monroe-Kelly doctrine. about the skull being a fixed box. It describes the relationship between the content of the cranium and the intracranial pressure. So in non-pathological states, the three components exist in equilibrium. And this allows us to maintain a normal intracranial pressure, the brain tissue, the blood, and the CSF. Small volume changes can be accommodated by compensatory mechanisms to maintain the ICP, but larger volume changes can lead to compensatory mechanisms being exhausted, and this can lead to significant increases in intracranial pressures and potential herniation. So just to go back to our case, immediately post-op, he was kept intubated and sedated. He was in our intensive treatment unit, and at this point, his pupils were equal and reacting briskly bilaterally. On the 30th of December, he had a repeat CT scan, and based on the results of that scan, which I'll show you momentarily, he was gradually weaned off sedation and extubated. So this is his post-op imaging. You can see there is no new hemorrhage. There's some mild herniation at the site. And this is just a good example where you can see the missing window from where the bone flap was removed. So it just demonstrates the effect of the craniectomy. So about acute subdural hematomas. A subdural hematoma occurs as a result of tearing of bridging veins from the cortex to the dura. The hematoma covers the entire brain surface, revealing a crescent-shaped deformity, and it requires rapid surgical evacuation, especially if associated with more than 5 millimeters of midline shift, and surgical intervention within the 2 to 4 hour rule applies. So it is, oh, sorry, if we could just go back a second, if you don't mind. Sorry, Rebecca. The mortality rate otherwise can be between 30 and 90%, and the morbidity and mortality is due to the underlying brain injury rather than the hematoma itself. So the treatment does require an early elective craniotomy or craniectomy. Thank you. So initial assessment and management, as everyone would know, primary survey and resuscitation. So airway, C-spine control, breathing and ventilation, circulation, disability, and exposure. If the GCS is less than 8, they will always intubate the patient for fear that they can't maintain their own airway. Then there should be a secondary survey, head to toe, reevaluate, and perhaps consider any missing injuries or anything that's been missed in the initial presentation. That's great. So Glasgow Coma Scale. So it's a score between 3 and 15, and it's based on how alert the patient is. So we look at 3 factors. They're eye-opening, are they open their eyes spontaneously, to voice, to pain, or not at all? Verbal response, are they orientated, confused, saying inappropriate words, incomprehensible sounds, or not speaking at all? And finally, motor response. So do they obey commands? If not, can they localize pain? Do they withdraw from pain? Do they flex or extend to pain, but then no response at all? So back to our case, this gentleman was transferred out of ITU to a high dependency bed on the 7th, and at this point his GCS was 14 out of 15. He lost a single mark for being disorientated. He was fully dependent and required NG feeding. He was referred to the NRH, but was for full MDT input, and his recovery was hugely aided by occupational therapists, physios, speech and language, dietitians, nurse specialists, all members of the multidisciplinary team. So then 16 days post-operatively after his initial surgery, he was deemed to be doing well enough to consider cranioplasty. So he was brought back to theatre for cranioplasty. This was for multiple reasons, including protection of the skull and aesthetic appearance. A cranioplasty is when the bone flap is replaced and fixed with screws. And prior to the surgery, the bone flap was stored in the patient's abdomen, as previously mentioned. These can be autologous, such as in this case, using the patient's own bone flap, or alloplastic. So in autologous, the defect is repaired, as mentioned, with the patient's own bone. In alloplastic cranioplasty, an alternative material is used to cover the defect, but it should be noticed that autologous is preferential. Other materials that are used in alloplastic cranioplasties are things like MMA, which is strong, low cost, and heat resistant, a titanium mesh, which can give a good cosmetic effect, or a peak plate, which can be sterilized, is radiolucent, and won't create artifacts on further imaging. So if we move on to his next slide, we can see his post-op imaging. So you can see the defect that was visible in the previous imaging is gone. And this scan actually commented on the excellent anatomical alignment visible. So post-operatively, his course was complicated by an acute kidney injury and 2 failed TWOCs, but he is being followed up with urology regarding same. He was mobilizing with assistance of 2 in his Zimmer frame. He had adapted to level 1 fluids and soft bite-sized diet, and he was transferred back to his original hospital on the 20th. Okay. However, he did end up coming back to us a week later. He developed a new onset AFib, and cardiology were considering anticoagulation. Prior to starting that, they had got a CT brain for baseline, and they were concerned there was a potential fluid collection on the imaging and transferred him back to us. However, on return to us, his GCS was 15 out of 15. He had no focal neurological defects, and his repeat scan a couple of days later looks good. So he's now in a position to go back to his original hospital and work on his recovery with full input from the MDT team. Thank you very much. So just some take-home points. Remember, the skull is a fixed box. Subdural hematomas do need quick identification and decompression to prevent long-term morbidity and mortality. And the post-op neurosurgical patients require ongoing MDT support and benefit. Thank you very much.
Thanks very much, Anne. That's a very nice presentation. It's a really nice case in that the initial presentation was with a GCS of 3, and obviously that's usually a very, very poor prognostic factor, but you've shown how rapid intervention, particularly in terms of the hematoma evacuation, but also the decompressive craniectomy, has resulted in a very good outcome in this man. Are you familiar with the Rescue ICP trial? Do you want to say something about decompressive craniectomy, or?
I might hand that over to Mr. O'Brien to talk about it, if that's okay.
David is here.
Yeah. I'm happy to answer that. So to get back, that's great presentation, Suzanne. Fair play to you. You know, I did volunteer you to do it, by the way, but that's okay. And she's done it all on her own, most of it, you know, and she's only 3 or 4 weeks in the job. So getting back to this particular case, GCS of 3 and the CT scan like that, most of us would not have accepted that patient. And the reason I took him was pupils are reacting, but I think he also has some alcohol on board, which may have brought down his GCS. But if this patient had fixed and dilated pupils, I would not have taken him. When he arrived here, if his pupils were fixed and dilated, I would not have brought him to theatre, but his pupils were still reacting. So we took him to theatre, we gave him a chance. And it all turned out very well in the end, better than expected, because as you said, when you have something like that and the brain is herniating out during surgery, the mortality rate is quite high. You quoted up to 90%. He's just done marvelously well. And the reason why we brought him back recently, most of them, was because they were a little bit worried about him. They thought there might be infection. And I have a low threshold of bringing patients back with any mention of a threshold. There was a little bit of air in his frontal lobe, but that's pneumocephalus from surgery rather than from
We've lost him for a second, have we?
anaerobic bacteria. So he's been absolutely fine, and he's actually going back to.
We lost you there for a little bit, David. But yeah, it's a very good outcome for that sort of scenario. As a matter of interest, and just for those who are listening, if you said if he had arrived and he had bilaterally fixed dilated pupils with an acute subdural and a really bad head injury, you wouldn't intervene, which I agree with. And I think in that scenario, you're just doing then kind of heroic surgery that's not going to work. If however it was an extradural hematoma and the patient arrived, and just as they're arriving, they're fixing their pupils.
But I would have taken him to theatre, because the prognosis is much different, much better, because they generally don't have an interparenchymal component to their traumatic brain injury. So you give them a go. But for something like that, he's got, you know, mass midline shift, mass effect, interparenchymal hematoma. You know, that patient may have died on the table, you know, but he's done very well. One of the reasons I want to bring this as well is just, it's a very simple case. You know, rather than some esoteric, sexy case, this is just a bog standard head injury. And it just illustrates that, you know, if we get patients in a timely fashion, yes, we can do something about it and do with good results, you know.
Yeah, I totally agree. I think it is nice to differentiate the acute subdurals from the extradurals, though the extradural hematomas do extremely well, and we intervene even with fixed pupils if we get them quick enough, whereas the acute subdural hematomas have underlying brain damage, and very few would do well, and if they have fixed pupils, you're not going to save them. I did mention the Rescue ICP trial, and I just have it opened in front of me, and the decompressive craniectomy in Rescue ICP randomized trial, which was organized throughout it was an international trial headed by Cambridge in the UK, and it reduced the mortality rate from about 50% to 27%. So a lot of the patients that would have died survived, but the downside of it was that those in vegetative state increased from 2% to almost 10%. So we saved some people who maybe when you look back and you know, they would have an extremely poor quality of life and will remain in vegetative state. And also it increased the number of those in the severe disability group, again from 2% to about 8%. So decompressive craniectomy, you've demonstrated it really, really nicely where it can be very effective. But I think it's a little word of caution that sometimes we are asked to do a decompressive craniectomy and the neurosurgeon is hesitant, and the reason is you can really save someone's life but have them in like vegetative state for the rest of their life. So that's where the decision making can be a little bit difficult.
Yeah, particularly when you're dealing with the dominant hemisphere as well. You know, you just got to be mindful of that. I mean, this worked out very well, but we're mindful of the time. I mean, it's very difficult sometimes if you're at a distance to advise a colleague in, you know, a peripheral hospital, you know, that you say we're not taking the patient, you know. Because we're accountable and we're responsible for that decision. And we're very dependent on the details that we're given.
Totally, yeah. Hopefully we have an online referral system which we've been working on for many, many years, and it's finally up and running. Many of my colleagues and myself, including David and Donica O'Brien, have worked on it, and Michael Amu, one of our registrars, has finally got it over the line, and we are getting the kind of a conversation between the two hospitals on an online referral system, which is a lot more accurate and a lot better. Just in terms of cranioplasty types as well, Suzanne, and I know Michael Amu is on, and I know he did a study with David O'Brien that got published. Just in terms of types of cranioplasty, you mentioned patient's own bone flap. Is there anything, you mentioned some of the other types, peak. Will I get Michael's online, or David, do you want to comment? Or I did warn Michael, I might ask him to comment on the different types. I think there was a systematic review published, and also our own kind of Beaumont results. Yeah.
But I can say from our perspective is that autologous bone flaps had an infection rate, but part of that was if you do it over a long period of time because there's autolysis of that bone, whereas if you do it in a short period of time. So my aim was, okay, let's see how this patient gets on. If he survives, great, and I tend to put the bone flap in the same admission. But if you are intending to not do something and wait for months or months and months, discard that bone and use PEAK would be my preference. You can use custom bone as well. And that was a big study that Michael Amu, the registrar, did, a fantastic study with a couple of other guys. You can use ribs. I've used ribs in kids in the past, but generally speaking, the PEEK. The other thing is that if you've got a common unit fracture, or a common unit fracture or a compound fracture, you're definitely going to discard that bone. Don't save it. And if you save it, don't save it in a domestic fridge. Put it into a proper fridge.
Very good. I think Michael can comment on the different. There was a very good systematic review that Jack Henry and Michael Amu with David did. Michael, are you on?
Yes. Can you hear me?
Yeah.
Yeah, we looked at the materials used for cranioplasty. Well, we did one for kind of general cranioplasty, and we did a second one on trauma. With relation to trauma, autologous cranioplasty seems to be inferior to the other materials. The one we use here is hydroxyapatite and PEEK. So there was a higher infection rate from a meta-analysis of 25 studies with autologous cranioplasty, as well as aseptic bone flap resorption. The problem in the literature is a lot of centers, ours included, we don't follow these patients long enough. So over kind of 5-10 year periods, a lot of patients actually get bone flap resorption. So the general consensus is that if possible, in trauma, the bone flap should be discarded and for an alloplastic graft to be used.
That's interesting. The unfortunate thing about it is the things like PEEK cranioplasty and things like that are extremely expensive. But you know, it's free, as David says, if the patient's going to come back later, we tend to use PEEK. But the option of putting it in the abdominal wall is a really good one if I think we're going to do the cranioplasty on the same admission or soon after.
Yeah.
Very good. I think that's kind of covering things. I'll just see if there's any other questions. If anybody has burning questions, post them, or David, or Suzanne, if you have other comments, do. And if not, it's been a really good evening with really good presentations. I think both Suzanne's presentations just demonstrated really good, rapid response to a really difficult case with a very good outcome. And I thought Mark Sherlock did a very nice presentation on the sodium problems that we see in our patients. On that note, I'm going to wrap up. We're going to run this on the first Wednesday of each month at 6 p.m. So you will get some emails from the College of Surgeons about it. So every month, first Wednesday of the month at 6 p.m. Other than that, have a really good evening, guys. Bye-bye.
Thanks, Moses.
Thanks, David. And thanks, Mark. And thanks, Suzanne.